Swami and the entire team for this lovely joint speaker meeting. Now, we would like to sincerely welcome our guest speakers, Dr. Dhruv Joshi and Dr. Farzan Engineer, doctors who are working day in and day out during this coronavirus pandemic. We are lucky to have them today evening so that they can throw light on the topic, is Corona our future? Over to Rotarian Aarti Madhappa for their introduction.
Thank you, President Anupallavi. Good evening, ladies and gentlemen. I deem it a great pleasure to introduce our speakers today. We will be talking about what is uppermost in all our minds these days, the COVID-19 pandemic.
Hello.
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 Sunil,
Yeah,
can you put everybody on
mute?
Good evening, ma'am. Good evening.
Aarti, we are not able to hear you.
Sorry, I think they muted me too.
Can you start? You're on mute, Aarti.
Aarti, they muted you by mistake. Aarti, unmute yourself.
Unmute me?
Yeah.
Okay, now I think they have. So here I go once again. Good evening, ladies and gentlemen. I deem it a great pleasure to introduce our speakers today. They will be talking about what is uppermost in all our minds these days, the COVID-19 pandemic. Dr. Dhruv Joshi, MD, has specialized in internal medicine, pulmonary and critical care from the American Board of Internal Medicine. Dr. Joshi trained in pulmonary and critical care at the Cleveland Clinic Foundation, USA. He graduated medical school from St. John's Medical College, Bangalore. He's a Bangalore boy member, so we should be happy about that. Following which he completed his internal medicine training at the Good Samaritan Hospital. He's the co-founder of Cloud Physician, which is a healthcare technology company that remotely provides ICU expertise to hospitals that do not have access to ICU specialist doctors. He realized early in his career that technology can be a powerful tool to enhance quality care and that it improves the results. Dr. Joshi's expertise in the adaptation and implementation of various technologies such as telemedicine to improve patient outcomes in both high and low resource settings. During his residency and fellowship, Dr. Joshi has been involved in numerous projects focused in quality improvement of healthcare delivery. Several of his endeavors have resulted in peer-reviewed publications. Welcome, Dr. Joshi. It's a pleasure to have you with us today. Next, I'd like to welcome Dr. Farzan Engineer, who is no stranger to me. Dr. Engineer is the co-founder and joint chairman of Medwell Ventures, which offers home healthcare services in India under the Nightingale's brand and in South Africa. He is also the co-founder and chairman of SiteCare Hospitals. Dr. Engineer serves on the board of directors of Sun Pharma Advanced Research Company Limited and Site Space Research Private Limited. He serves on the India Advisory Board of Shirate Ventures. Dr. Engineer helped launch his international CRO industry in India and served as chairman and CEO of Quintiles India from 1997 to 2010. He was also a member of the Quintiles Asia Pacific Management Board. A warm welcome, Dr. Engineer. Thank you for agreeing to come and talk us through the ways and means to help equip ourselves to get through this dreaded pandemic. Before I hand over to the doctors, I would like to mention a few lines about Nightingale's Home Health Services, which is a Mahindra collaboration and is also a Medwell Ventures owned brand with over 2 decades of pioneering experience in India. It has developed a strong focus on specialty home healthcare services in chronic diseases including pulmonology, cardiology, neurology, metabolic diseases, orthopedic geriatrics, and post-operative rehabilitation. Additional services including remote health monitoring, diagnostics and wellness therapeutics that provide holistic patient care. Nightingale ensures excellence in patient care through a validated protocol and a care core plan with approach for chronic diseases. Over to you, doctors. Pajan and Dhruv, over to you.
Thank you. Thank you very much. Thanks for inviting us, Bharati. Maybe we could start with a few comments and then make the session more interactive. It's a great pleasure to be here, and I think both Dr. Dhruv and myself have been very busy since the Corona crisis started in March. As Arati mentioned, I run, I'm co-founder of a cancer hospital called SiteCare, and I also run a home healthcare company called Nightingales. So we have seen COVID both in a hospital setting and in a community setting. And through one of our other companies, also in a research setting now, as more and more research is being done in this area. If you look at the history of this problem for our country from March, we only had about 20,000 cases in April. So in the first 30 days or so, it was only 20,000 cases. Our cases adjusted for population was and still are very small, and so are deaths adjusted for population. So, for example, our cases per million are about 700, whereas in the UK it's 4,000, in the US or Brazil it's north of 10,000. So if you see the early days, we did very well with COVID. We locked down, we were able to control the disease. And then out of economic necessity and also the difficulty of managing this in a very populous environment, cases started rising very dramatically. And right now it's at a point where the trend is very disturbing. So about 60 days, maybe a bit more, maybe 70 days back, we had about 100,000 cases. We had 1 lakh cases. A few days ago, we crossed 1 million, and now we are probably at 1.3 or 1.4 million. And obviously, we can't test everyone. In most countries, they don't test everyone, even more so in our country. So the actual number of cases would be much higher, maybe 3 times, 4 times higher. We do not know. And the trend is very disturbing because it's going up by an order of magnitude in 2 or 3 months. So at this rate, we could have 100 million infected people. And therefore, these partial lockdowns for a few days, I suppose, become very necessary. I think now in the last 3-4 months, it's also important to distill the learnings that we have had in different states with different approaches, because a lot of things have gone well and a lot of things have not gone well. And it's very clear that we need more testing, we need more rapid testing, more widespread testing. We need facilities for home or community quarantine, because about 95-96% cases don't need to go to a hospital at all. A large percentage are asymptomatic or they have mild symptoms, which can be easily managed by proper isolation and discipline in a home setting with relatively easy to deliver care and medication. It's only the 3 or 4% who end up in hospitals who really need our attention, and therefore it's also important that hospital beds are kept free, ICU capacity is kept free, the necessary equipment is kept available, and scarce drugs are kept available for those 3 or 4%. Even out of those 3 or 4%, a much smaller percentage, maybe 1 or 2%, need ICU care. So I think the whole approach, if you see the early success in our state and some of the other states which have now become quite successful in containing the disease, would mean you test, you quarantine and isolate as appropriate, you keep people out of the hospital, you intervene with patients digitally, not by sending doctors and nurses and neighbors and friends, but you intervene digitally. In most cases, the disease goes away in 10 12, 15 days. Uh, uh, and then you have the capacity and the resources left uh, to manage uh, the serious cases, the moderate cases, cases of people of above a certain age with comorbidities. So this really was running in the early days in Karnataka, and now certain states are doing a good job, and they're following this trend. And by controlling the disease in this way, and also therefore enabling the economy to at least survive at a moderate level, if not at its full potential. We are also buying enough time and experience. So I'm sure Dr. Dhruv will talk about it, but now we understand a lot better which drugs work and which don't work. A lot of things were tried. Obviously, there's a lot of chatter on the internet. Uh, and now I think we have a more scientific understanding of what approaches, what drugs, what therapies work and what don't. And if we keep buying time like this, we will have more experience. We may have some sort of an immunological solution, a vaccine or something similar, access to drugs which are shown in scientifically designed trials to work, etc. So I think we are sort of at a stage where we locked down and did well, then things went out of control. Now we have learned what works and what doesn't work. There's scientific progress. And I guess now we have to see what happens. No one really knows for sure. But certainly every day we are learning, and we should apply those learnings to safeguard ourselves, our families, and our community. I think home healthcare has a big role to play in decongesting the hospital infrastructure. So we do COVID tests. We've done thousands of teleconsultations. We have a teleconsultation platform which we developed with Tech Mahindra, which is a big IT company. We have dozens of qualified doctors who are able to help people over the telephone or on a video consultation. We are then able to monitor people when they're isolated at home or in quarantine centers. And when the highest level of expertise is needed, uh, 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 I think there are very few experts in the country, maybe even in the world, like Dr. Dhruv and his colleagues, who are highly trained intensivists and pulmonologists, both by qualification, by training, and by, by experience. So their company, Cloud Physician, also manages the ICU at our cancer hospital. And obviously in a cancer hospital, it's very intense because you're dealing with cancer and sometimes COVID at the same time. So we collaborate, we work together. Nightingale's does the home healthcare bit, and Cloud Physician, with a very high level of expertise, provides super specialized care. So I think we're all trying to do our bit in this environment. And with that, I'll hand over to Dr. Joshi.
Thank you, Dr. Farzan, and thank you everybody for inviting me. It's a pleasure to be here. I'll just keep my comments short, and then we can make it more interactive. And I'll just speak to two things. I'll speak to a little bit about the healthcare infrastructure as it exists, and then a little bit about the therapeutics available at our disposal in treating COVID-19. So I'll segue into the infrastructure a little bit by giving you some of my background, some of which Aarti already shed some light on. Me and my colleague Dr. Dilip Raman, we were both doctors working in the United States, and one of the things that we realized was that there was a huge shortage of ICU specialist doctors in India. And it was that motivation that led us to move back and to start our company called Cloud Physician. What we also realized very quickly was that there's no way it takes more than a decade to train an ICU specialist doctor or an intensivist. And 9 out of 10 patients in India don't have access to ICU specialist doctors when they need them, when they're in ICUs. Unfortunately, there's no way in which we can train enough people and deploy them in all the ICUs that they need to be. And therefore, we need to leverage technology to be able to deliver this expertise as and when it's required to help the patients that find themselves in ICUs. So it was with that motivation that we moved back to India. Now, just to give you a sense of how big or how bad the problem is that even before COVID was upon us, like I said, 90% of ICUs, even in urban centers like India, do not have ICU specialist doctors available round the clock. And ICU patients are the sickest patients in the hospital. They are the ones that very often need access to these specialists, sometimes at a moment's notice, because that's how quickly things can change in an ICU. And with this gaping shortage, now that COVID has hit us, this shortage has only been exacerbated, and essentially this fault line that already existed in our healthcare delivery system has been exacerbated several fold. So now we are hearing about, firstly, the unavailability of ICU beds. But even if you were to find an ICU bed, very often you will find that, there's not adequate nursing. The specialists that you need at your bedside when you are in these ICUs are simply not available. That is the existing scenario that we're dealing with. And hence it is incumbent upon all of us, including the government, to find innovative ways to deal with this crisis. Unfortunately, it's not possible to build hospitals overnight and build ICUs and train specialists and train nurses overnight. That's just not realistically possible. As a result of which, we have to carefully utilize the existing infrastructure that we have in the best way possible, in the most efficient way possible, and in a way by which we are able to take care of our patients when they get admitted to hospitals. Now, one of the ways to do this is to decongest hospitals, because it is simply not going to be possible for everybody to get a hospital bed, and is probably not even in the best interest of the patients to be in hospital beds if they don't absolutely need to be there. Hospitals are places where the chances of co-infection are significantly higher, even from a mental stress, from a sleep, and from an overall well-being standpoint. If you don't need to be in a hospital, you probably should not be. So it's really important for us to now start leveraging home care, home quarantine, home isolation, using telemedicine, using digital methods to be able to safely and efficiently take care of ourselves at home. And that would allow the existing infrastructure that we have to cater to the very severe ill and the critically ill patients that we have. Unfortunately, as things stand, uh, that is still not going to be enough. We are still going to find ourselves in a position where, even with all this decongestion, it's highly likely, and we're already seeing it, that we are going to be overwhelmed by the number of patients, by the number of cases that we have. And as a result, we need to do everything possible to reduce the transmission of COVID, to help avoid that scenario from getting worse. So I guess that's a little bit of where we stand in terms of a healthcare infrastructure. It is, as it stands, woefully inadequate. Hence the need to develop solutions to be able to take care of ourselves, and to reduce transmission, so that we don't get to a point where we constantly reading about every day's newspaper just throws up more reports of people with their family members running from pillar to post, from one hospital to another, unable to find themselves a hospital bed to help very often even save them. So with that, I'll sort of just segue into the next point that I'd like to touch upon, is that the current scenario that we are seeing is unprecedented in many ways. Also in the way that, you know, we're now living in a social media world, we're living in a 24/7 news cycle world, and so there's a lot of information that's coming through. Very hard for people to digest what is actually right, what is actually wrong, what makes sense, what doesn't. Very often it's difficult for even doctors who are not, you know, very well trained in sort of, you know, reviewing the literature that exists and looking at things very scientifically to make out, you know, what is the truth and what isn't. This is definitely getting better now that we have a few months behind us, where we now have some data on which to base our decisions, where we can now distinguish between you know, legitimately scientifically proven treatments versus just hearsay and WhatsApp forwards and just conjecture. Because as doctors, our you know, our goal number one is to do no harm. So so, you know, in the current scenario, it's very easy for us to say that, you know, let's just give somebody something because we heard about it, but that may not always be in the best interests of our patients, and hence it's even more imperative that we do no harm and we use a scientific basis to help the patients that we're taking care of. With that, I'll just conclude my opening comments, and happy to make this more interactive, and you take questions from the audience. I'm sure there are particular things that they may want us to discuss.
Okay, let me start. The last time we spoke, you spoke about having home care and setting up, units in within communities. Can you tell us a little about that?
Yeah. So, you know, speaking to the point that Dr. Farzan made, and also what I was referring to, is that unfortunately the healthcare infrastructure as it stands is simply not robust enough for us to take care of the entire population, or for the government to take care of the entire population, or even for hospitals that are existing to take care of everybody. As a result, it is imperative that in this scenario, organizations, apartment buildings, residential organizations, take some onus upon themselves to safeguard the interests of their community members, their families, their friends, their neighbors. In this setting, like I said, you know, the existing infrastructure, the hospitals are not the best place for most people to be at. And if there are people who turn COVID positive, which will inevitably happen in most communities, it's bound to happen. That we have a system by which, if they are merely mildly ill or asymptomatic, that they be managed appropriately within the confines either of their home or within the confines of their apartment complex, their apartment building. And that would probably be the best solution. And so towards that, Dr. Farzan and their organization Nightingales have now, in fact, deployed several such solutions at many apartment complexes. And I'll let him talk about that a little bit more.
Thanks, Dr. Dhruv. As I was saying earlier, it's mostly in the digital domain. So we typically sign up an apartment complex. It gives them access to teleconsultation. And now we are able to do this 24/7. So anyone in the community with any symptoms can access by telephone or video a doctor and discuss his or her symptoms, and then be monitored by that doctor. And if the symptoms so suggest, then a COVID test is done. We can organize it within our ecosystem with a partner lab, or they can get it done from any government center or laboratory. At this stage, The only reliable test, in our opinion, is the RT-PCR test. It takes longer, it's more expensive. But after the first 2, 3, 4 days, it should be highly reliable. Typically, theoretically, one would not get a false positive. So if someone is positive, it's definitely COVID, and then one can treat the person and isolate appropriately. Um, there are also antigen tests which are interesting, but you get a lot of false negatives. Therefore, maybe in this particular example, not the best option. So then we would get a test done, and if the person was COVID negative, the doctor would just continue treating the patient for whatever, flu or dengue or anything else that the patient might have. And if the patient is COVID positive, and if the person's age, comorbidities, and residential situation, and I believe people on this, in this thing would have residences that would allow a separate bedroom to be carved out for that person, or some sort of arrangement in a communal setting where the person can be. And then our doctors would monitor that patient depending on need once or twice a day. Nurses monitor the vitals. The necessary minor equipment and medicines are delivered to the doorstep of that home. Uh, we can also have nutritionists, physiotherapists, psychologists, etc., call into the family as needed. And in most cases, in the vast majority of cases, that should suffice. And then the person, whatever the current rules are, I think for people who are asymptomatic or mildly symptomatic, you isolate for 14 days after the test result or 17 days after taking the test. Current guidelines don't require you to test again. I suppose one could elect to do so under certain circumstances, but there is no reason to test again if the person is without symptoms. And that pretty much contains the problem in the home, or at best within the apartment complex where the person resides. On some occasions, the case will get very complicated, and it is beyond the scope of a general practitioner. And in such a situation, you need super specialized care, which in my opinion is extremely rare to access anywhere. And that's where I think cloud physician is a big boon, because you can actually 24/7 talk to an extremely qualified intensivist or pulmonologist and be guided. In the apartment complexes that we serve, in most cases jointly with cloud physician, we also have a couple of oxygen concentrators, a few other things, PPE kits, etc., available in the community hall. By law, and also in reality, we don't think cases which progress beyond mild should be managed at home, or for that matter, even in a community setting. When a person becomes moderately ill or seriously ill, they really need to go to a hospital. And I think if we manage this well and keep 95, 96% out of the hospital, then arguably there would be enough capacity, especially if we also follow social distancing and do all the other things. Then there should be enough capacity within hospitals to manage the patient. So just to summarize, we would do a package which would allow the community teleconsultations, COVID testing, and other types of testing as needed. Then isolation at home under digital guidance, so to speak. And in the rare cases where things turn serious, then cloud physician helps them at a super specialist level. And after that, for the 2 or 4% who who need hospitalization, one then makes best efforts to find the right ambulance and the hospital bed or the ICU bed uh, as needed. So that's sort of a snapshot of what we do.
Rotarian Manjunath wants to ask some question, it seems.
Yeah, good evening, Dr. Dhruv and Dr. Farzan sir. Firstly, we should salute you for all the doctors from Rotary. Secondly, I just want to ask a simple question. There is a vaccine we are seeing in the TVs. There are more than 20-30 vaccines are there displayed, but we are really confused and also not able to understand whether the vaccine is really happening or when it will happen. Any idea about that, sir? Thank you.
Yeah, hi. Thank you for that question. I think there's a lot of, like I was saying, there's a lot of media coverage on this particular issue. There are many, many, many vaccine trials going on, and you may be right. I don't know if it's 30 or even more than that. There's a race to a vaccine that's going on. You have the Chinese, the Germans, the Americans, India, Australia, many other companies all simultaneously working on this. As of right now, there is no vaccine as of today, right? Best case scenarios, you have, the Gates Foundation, led by Bill and Melinda Gates, is probably one foundation that has been working extensively with vaccine developers and vaccine manufacturers, trying to set up the supply chain and that irrespective of where the vaccine is first developed, it gets to anywhere in the world that it is required. And even the Gates Foundation, as of right now, or Bill Gates, in an interview that he gave just 2 days ago, was speculating that probably early next year is the best case scenario for a vaccine. Now we can all hope for the best, and maybe one of these vaccine developers may develop a vaccine that works sooner than that. There will still be challenges in mass production of that vaccine and of distribution of that vaccine across large populations, because let's remember, we need billions of doses of whatever vaccine is developed for it to work. And so I think with vaccines, our approach should be to hope for the best, but be prepared that a vaccine may not come onto the scene even up until the middle of next year. And we should be prepared for that eventuality. We can, like I said, we can keep our fingers crossed and hope for the best, and hope that it comes sooner than that. But it is possible that it may not arrive even up till the middle of next year. So that's where vaccines stand. As of right now, the vaccines are in different phases of their trials, but there is nothing right now available for use. And there won't be, at least in the next couple of months, until we hear more.
I think that's
Thank you, sir.
very well said. And if I could add just one or two things, I think many of these vaccines are in early stage phase 1 and 2 trials, where they've been tried on a limited number of people. And now they're entering larger phase 3 trials. But just to elaborate on one thing, even if we get a successful vaccine, it is not clear how durable the effect of that vaccine will be and whether it will fully protect us. So I think it's probably unrealistic to expect a magic bullet that once injected will secure us permanently and then we can go back to our good old or bad old ways. It will probably provide some level of protection for some amount of time. How much protection and for how much time needs to be verified. I think the current vaccines are producing antibodies, but how long these antibodies will last and how long they'll protect us. And then even if we don't have those antibodies, does it then prime the body to deal with the vaccine more effectively? A lot of these things are in the realm of speculation rather than fully being investigated scientifically. So I would only add here that even after the vaccine comes, one might still need to continue being very cautious and reduce incidence. And it probably may not be a magic bullet which protects us fully.
Hello, can you hear me?
Yes, sir.
Arti?
Yes, sir. We can. Yes, Mr. Menon.
Dr. Farzan and Dr. Joshi, this is an outstanding talk that you gave us. In the private need of being brief for time, may I ask both you gentlemen to take a hypothetical case? Should I suspect that I'm infected today? Suspect, that's the key word. And is it possible for me to reach out to both your organizations or somewhere? I can be entirely clinically analyzed sitting at home. Instead of me trying to run around the city looking for doctors and hospitals, is there something which you readily is on offer from your organizations? And going forward, one question. The first stage is I am infected. I am suspected of being infected. Second one is there is a proof that there is an infection. Third one is whether it is asymptomatic, simple, moderate, or serious. Do you believe, except for the state, Dr. Farzan said that if it becomes too serious, you have to move to a hospital. Fair enough. But you mean that nearly 90% of the cases can be treated at home. Our questions to you is, doctors, what is the minimum infrastructure that we need to have in our community group to be able to do this seamlessly with you? Is it enough if I have a broadband connection and a screen device so that I can communicate? So this is the basic question, and I think what you're offering is something outstanding. And if there must be packages, you did touch upon that, Dr. Farzan. So how do we get more information on this?
I think you're largely correct. That's about all you would need. I don't think you would need to be tested if there are no symptoms. So I think if you're healthy, I wouldn't really test or even think about testing unless you came in contact with someone who was infected. Then one might want to think what the nature of that contact was. And it is also now clear that if you wear a proper mask and the other person is wearing a proper mask and you are socially careful in terms of how far you are with the other person, discipline of washing hands and so on and so forth, then even if you come in contact with a COVID positive patient, it may not actually infect you. So assuming you're healthy, I think everything is fine. If you develop minor symptoms of some sort, which could be indicative of any other minor problem, it doesn't have to be COVID. I think that is the confounding factor right now, because one could even get a regular flu. Then I think all you need is an internet connection. You can contact us. Our doctor will teleconsult with you. And if there is reason to monitor you, at your doorstep, we will deliver a device which measures your oxygen levels, simple vitamins and medicine that would be delivered to your doorstep. And then on telephone, you would be monitored by doctors and nurses, tested if required for COVID. And in most cases, that's probably all you need: a teleconsultation, a small kit which is delivered to your home. It could be in the digital domain as straightforward as that.
Thank you so much. Last question, taking on from there. I'm talking real time. We are on the day zero today. You are saying that anybody in this community that I live in, should we have a problem, can reach out to you. And from there, you all will take it on. Is there any marketing department or somebody that we could consult in your hospitals now itself? So we are a community of 60 people, and it's not unlikely that at least 5% will go through some infection in the next 2 months or 3 months. Is there some way we can understand the cost of a package? And is there somebody we could reach out to?
Yes. Right now, I'm happy to be that somebody.
That's wonderful. Thank you, doctor.
kindly invited me here. I'm very happy to interact with you, sir.
Thank you so much. Thank you. That would be all. Thank you very much.
Mr. Rotarian Raghunandan have a question.
Yeah.
Raghunandan, please.
Yeah. Sure. Can you hear me?
Yes.
Yeah. So thank you, Dr. Engineer and Dr. Joshi, for a fantastic talk. Very useful. And the need for decongesting hospitals and home health care is one issue that was brought about very well, and that is understood. The other problem that was highlighted in terms of 90% of ICUs not having ICU specialists, and that's where Dr. Joshi, you came back to India and you're taking this initiative. That initiative in this context is not something not fully understood by me. Let's say if we do take home health care, and let's say if there are situations that require critical care, you can shift to hospitals, and there you still have this problem that you mentioned, that 90% of the hospitals don't have it. In which case, how are you going to be in a position to help, given that you have that expertise? That particular point is not understood.
Yeah, there are a couple of ways in which we can help. One is we already work with hospitals. Actually, our primary focus is working with hospitals and providing them with this expertise. So we have tie-ups with a few hospitals. One of the hospitals is one that Dr. Farzan runs in North Bangalore. Outside of that, what we are doing now is that for patients who uh, have get themselves admitted into ICUs and still require, a second opinion, we are providing them with access to our specialist doctors. And talk to the patients, talk to the families, coordinate with the doctors who are going to be managing these patients in these ICUs and helping ensure that the patients are being appropriately managed. So this is something that we have started in this current scenario, realizing the problem that you just highlighted. These are the two ways. Now, as like I said, that's what we have available right now, and that's how we want to help people in that situation.
So the the way we can leverage cloud physician is only after we go and get admitted to a hospital.
Yes, yes,
Okay.
yes. But even before that, in especially in the we have tied up with Dr. Farzan's organization Nightingales, where they are offering their packages, and as an added service, they have access to our specialist doctors, even if they require them at home, especially in cases where things are getting more complicated, that are beyond the capabilities of a general physician, and that require either the specialized attention of a pulmonologist or an intensivist to help guide the patient or help guide the family in those situations. We are available in those scenarios.
All right, just to kind of complete it, this is very useful. So in such case where a home care patient who's already leveraging home care facilities through Nightingale, and we could probably get some initial questions answered from you, but would this package also help the patient to find the appropriate ICU facility and coordinate that particular arrangement as well?
So let me respond
Sure.
to that.
Sure.
Typically, for most cases, our doctors should be able to manage digitally. And then if someone is at the cusp and you're not able to decide whether one has to go to the hospital, there are other comorbidities, then cloud physicians taking over, again in the digital space, would be extremely reassuring, because then you know that the decisions which are taken at the highest level by the top ICU people. And we often quote the shortage of beds, and it is true, there is a shortage of beds. But so there is an even bigger shortage of people and expertise. There's a shortage of doctors, there's a shortage of nurses, acute shortage. even more acute shortage of ICU trained nurses. Uh, uh, so just the fact that this level of expertise that cloud physician has is available at home for the handover to the hospital, and in some cases even continuing once the person is in the hospital, is, I think, a very big thing. It still doesn't solve the problem of brick and mortar infrastructure, because beyond a point, you can't do things digitally, then you actually need the physical infrastructure. There is absolutely no way anyone can guarantee a hospital bed or an ICU bed. It's impossible. It is practically not possible. It's legally not possible. So when the situation arises, depending on where the person stays, their insurance, their economic situation, their health condition, one would have to scramble various resources and find a hospital. The hospital I'm part of, where I have the most experience, is a cancer hospital. So that's not the right place in this situation, because cancer patients are immunocompromised. That's not where you want to send a patient, unless the patient is a cancer patient. That's a different. Typically, a multi-specialty hospital with a strong ICU, hopefully an ICU supervised by cloud physician or someone of equal competence, would be the right hospital. And then one would have to quickly look for a hospital. Would help the people that are able to act and not.
Doctor, we missed you. We were not able to hear you.
Yeah. Fijan, we couldn't hear you.
You couldn't hear me at all?
No,
The,
not
the
at
last
all.
part.
Yeah.
The last few
Now I can
sentences.
hear.
We lost
last
you
part.
in the last few
I'm,
sentences.
I'm sorry. I think the internet became unstable. I don't know where you lost me. I was basically saying that when things get complicated, cloud physician would be able to take the right decisions. And then when a hospital bed has to be identified, uh, uh, you can't block a bed in advance. So depending on where the person lives, their health condition, their insurance, their economic situation, one would then have to look for a bed when the situation arises. And sometimes it takes time, and therefore, again, access to cloud physician would be very helpful.
All right. Thank you.
Next question is from Shrikant, Rotarian Shrikant.
Yeah, good evening, sirs, Dr. Drew and Dr. Farhan. Nightingales is something I've been familiar with even for the last 10 years. I think that as a concept, they started home servicing and I have used them extensively. My question is that now that we're talking about shortages and COVID or no COVID, these shortages will be there. How long will it take to, say, train a nurse? I mean, a doctor is something which is, beyond Rotary scope. But Rotary as an organization can definitely train a lot of nurses and other downside healthcare professionals with, their volunteers, with their money, with their, maybe in other rural areas and other things. So my question is, how long does it take for these healthcare professionals to be trained, which can be used by doctors or hospitals or others?
I think Dr. Drew would have more experience. I have a point of view, but I will defer to him and maybe then make a comment.
Yeah. So training nurses, it's a great question, and thank you for even showing interest in solving a major problem in healthcare delivery as it stands in India today. So I'm glad that people like you and Rotary as an organization is even coming forward to help in solving this problem. Training nurses is not easy. So just to give you a sense of where we stand in terms of nurses, unfortunately, we have huge number of nursing colleges in our country today. In fact, to the extent of almost 2 lakh nurses a year is what the nursing colleges are able to put out. That is, there are two types of nursing courses. One is a GNM and one is a BSc. So the GNM is General Nursing and Midwifery, and a BSc is a Bachelor of Science in Nursing. And these are usually 3 years, 3 odd year courses, and huge numbers of nurses are churning out from these programs. Unfortunately, the reality is such that the nurses coming out of these programs are simply not employable, in the sense that they lack the skills to actually take care of critically ill patients. So even though we have these large number of nursing schools and nurses coming out of these places, they are simply not employable in most settings. Now, also, I want to just sort of talk about, in terms of nursing itself, there is a spectrum of nursing skills that a person can be taught, right? So there's just basic nursing, where basic, just putting in an IV, taking measurements, vital signs, administering some basic medications, being able to document that, and having some basic nursing knowledge. Those are some basic nursing skills which can be trained relatively soon. And at the other end of the spectrum, you have nursing skills that are required for critical care nurses or nurses in ICUs, which involves maneuvering ventilators, changing settings, addressing alarms, being able to interpret signs and interpret basic ECGs, which also involves being able to administer highly toxic medications to patients, being able to give them in the appropriate doses, give them appropriate concentration and strength, and administer it at the appropriate speed. That requires definitely a further level of training and of experience and of working in ICUs. Uh, just to give you some more insight, we have a curriculum for training these nurses, and that curriculum spans from 2 weeks for nurses who already have some basic level of knowledge, and they need to be upskilled, to up to 3 to 6 months, where you need to actually skill them right from the start. So it ranges in that range. But to your point specifically, if you would like to take up this cause, there's certainly some resources that we could work with to see how we can train the nurses for the appropriate settings in the appropriate regions, whether it's ICU or whether it's basic nursing. It would be helpful to train nurses across the spectrum. But that's where it stands. Usually an entire nursing course is about 3 years to upskill these nurses and make them employable and make them be able to handle conditions that they need to, can range depending on where they've graduated, from anywhere from 2 weeks to up to 6 months, like I mentioned. Dr. Farzan, I'd love to hear your take on this.
I think this is a burning issue and something which we haven't addressed as a country. I think it's also a profession that is extremely significant. I would say it's as important as any other practice within a hospital. And it hasn't gotten the level of respect, attention that it deserves. So if you look in many other countries, a nurse is very highly trained, very well paid, very much respected, and very much a part of the decision-making process in treating patients. This is not true in our country. So I think there are two things. One is we need shorter-term fixes, and definitely these kind of training programs would be the need of the hour, and if Rotary could do something, that would be great. But I think at a more fundamental level also, we need to look at nursing as a profession and uplift it to the level that it needs to be at. There is also a huge efflux of nurses after about a couple of years of experience because they go to better paid countries. I would say maybe we should pay them more. I mean, if you want these services, and now we are realizing how difficult things are, uh, uh, we need to pay them at par with other top professionals. So I think at a more fundamental level, even at a cultural level, at a professional level, this is a profession that needs to be uplifted and respected far more than it is today.
I absolutely echo those sentiments. We are seeing a huge rates of attrition in our nursing staff across the country today, because this is like Dr. Farzan mentioned. This has been a profession that has not been accorded the respect that it is due to it over all these years. And overnight we're expecting that nurses come to the fore and quite often in some scenarios even put their lives on the line in some of these hospitals that are not don't have the proper equipment, don't have the proper processes in place to for nurses to protect themselves. And so it's hard to expect the nurses to step up in such a scenario. They not never really have been compensated fairly, either in terms of monetary value or in terms of respect that they deserve in their professions. And for now to expect them overnight to be at the forefront and help us out when we've never really helped them out as generally in the entire healthcare delivery system, I think this is a flaw that needs to be corrected.
Okay, just one very quick question. You spoke about packages for apartment. What about individual homes? Do you have anything for people who live in individual houses?
Sorry, Arthi, I was on mute. The same thing. We can offer the same thing at an individual level.
Okay, thank you.
Any other questions? If there is no other question, let me ask
Hi,
one.
this is
Yeah.
this is Anand.
Yes, Anand.
Hello, doctors. I just
Anand,
want.
can you switch on your video?
Yeah.
Yes, Anand.
Yes. I just wanted to know what are these packages? More details on the packages, the cost, and what forms part of these packages for a basic care. Thank you, doctors.
What does a basic care package cost? So one package, depending on the size of the community, would cost a few hundred rupees, about 900 to 1,000 rupees, which for 3 months would give access to unlimited teleconsultation.
Oh, nice.
And then, and for the vast majority of people who don't get sick, that's all they would pay. And then if someone needs attention, if someone needs quarantine, home isolation, monitoring, etc., the packages range from, I think, 3,999, about 4,000 to 15 or 16,000 rupees, depending on how many services are taken. Those packages are typically offered over a 2-week period. And then if super specialized consultations are needed from Dr. Dhruv and his colleagues, that is an extra charge, because that obviously is a special situation requiring an unusually high level of expertise. So these packages are quite affordable, really. And oh, I forgot, the COVID test would be extra, and the government keeps mandating the price at different times. I think right now it's about 3,000 rupees in a private setting. That's the latest government pricing. So I think it's quite affordable, and taking these packages give a clear line of sight in terms of what one must do if there are symptoms within the family or with a friend or whatever. So it because otherwise people are confused. They try and ask around. They try and rush to a hospital that they don't need to rush to. I think these packages are good in the sense that there's a clear direction in terms of what needs to be done. They work very well, I think.
Thanks a lot, doctor. Thank you. It really helps.
Thanks, Anand. Any other question? Madhusudan, you have a question? Rotarian Madhusudan, do you have a question?
No. Just observing.
Okay, okay. Doctor, one question from my side. I'm Sunil Sahadev. At what stage one should think about the hospitalization, even if the saturation level is okay, but the fever is not going, let's for 14 days. Still the fever is there, although it's not a high-grade fever, it's a low-grade fever. Is there any other symptom when one should get hospitalized other than the saturation level?
Yeah, I'm happy to take that. So, unless there is a suspicion for some other, in patients in special instances where they have, other comorbidities or some immune suppression for some other reason. Again, this is something that a doctor, a qualified doctor, will be able to walk you through and help you with. Outside of that, I know that and I get a lot of these calls. That's why I know some of the concerns that people have. People who are having low grade fevers, which can last for several days, even sometimes up to 10 days, sometimes even up to 2 weeks. Provided that outside of that they are generally doing well, they don't have any shortness of breath, any difficulty breathing, they don't have significant change in their energy levels where they become lethargic, or they have become where they are becoming obtunded or unresponsive, um, or their saturation levels are dropping. Outside of these scenarios, all of the other symptoms are very often a part of the constellation of symptoms associated with a viral disease like COVID. And very often, viral disease like COVID can actually have some post-viral syndromes where you may have a slightly protracted cough that may even go into the third week or fourth week. It is not cause for concern in the absence of any of the other things that I mentioned to you, in the absence of any other serious comorbidities, or change in the mental status of a patient, or significantly worsening shortness of breath or breathlessness. These can actually be managed at home. What it does require you to be in touch with a doctor who can walk you through this, who can assist you in these scenarios, and ensure that there is nothing else going on that mandates that you go to a hospital, and provide you the symptomatic treatment or the therapeutic treatment that is needed, which can be delivered at home. So the takeaway that I want that I would leave you with is that, uh, provided that you don't have any severe symptoms, and you have access to a doctor, um, things can be managed at home, even if they were to go into 10 days or 2 weeks or even 3 weeks. I would still recommend that if there is no pressing need for hospitalization, that patients be managed at home. This is not the setting that you want to be in hospitals, even from a personal standpoint, and even from a population health standpoint. Hospitals are better avoided if they can be. If on the other hand there are any of the symptoms that I mentioned, either your oxygen levels are dropping, your shortness of breath is worsening, or you are having some sort of a chest pain that requires further investigation, or you have other comorbidities or other conditions that mandate further investigation which cannot be done at home, then you should immediately start making arrangements to be transferred to a hospital.
Thank you.
It's hard for people to sort of decipher this on their own, and very often there's no clear-cut algorithm as such that people will be able to figure this out on themselves, and which is why it is helpful to have some sort of a digital access to a doctor in these scenarios.
Thank you. Thank you, doctor. Any other questions?
Hello,
If there are
sir.
no, yes, sir.
This is Suresh. Doctor. Hello, doctor. I have seen in some pathologic lab entrance and bank entrance, etc., they use the thermometer gun. The gun shows temperature about 80, 85, 90, 95 degrees. But never they show more than 98, which is supposed to be the correct temperature. So whether the thermometers are not showing correct or they are not calibrated. And if this is the case, what about the oximeter? If the oximeter also shows the same thing, how to believe whether the oxygen level is correct or less or more? That is the question.
Yes, it's a very valid point made by you, Mr. Suresh. If the temperature gun is showing that somebody has a temperature of 85 or 90 degrees, either that person is extremely ill, or the temperature gun is miscalibrated or wrong. Those are the only two things. It's impossible for someone to be walking around with a temperature of 85. I have noticed this myself. I live in an apartment complex, and our apartment complex has an app which shows the temperature of people entering. And very often I see a temperature of 89 degrees, and I see a perfectly normal person show up at my doorstep. So obviously there is some miscalibration in that temperature measurement, and it is not correct. The normal temperature, if you have a temperature in the 80s, you are severely hypothermic, and very often I keep a blanket ready when I see that
Correct.
coming in with a temperature like that. But jokes apart, there are problems. These are very real problems that you have highlighted in terms of the quality of the equipment that is available to us. There is a lot of opportunistic folks who are flooding the market with different types of devices in this scenario, sometimes unscrupulous as well. And it is easy to fall prey to some of these malfunctioning or devices that don't work very accurately. So it's helpful. There are certain brands that are well validated. If you use those brands, it's always helpful to stick to some of those brands. There are many of those, but it's a valid point. I don't really have a great answer for you, other than to tell you that if you do see a temperature of 85 90, you should point it out to that person that temperature measurement device is not accurate and is not working. It should be checked out or replaced. With regard to the pulse oximeter, again, it's important that we get pulse oximeters that are functioning. One way to check the pulse oximeters is actually to use it on multiple fingers. They usually give you a heart rate as well. That is a pulse rate. The pulse oximeters actually give you a pulse rate. There's an easy way by which you can check your pulse rate yourself. Just check your pulse on your wrist and then see if that calibrates with the pulse oximeter. It'll tell you whether the pulse oximeter's pulse rate is correct or not. So these are easy tricks that you can use to ensure that some of the readings on it are accurate or not. But nonetheless, it's a valid point that you make.
And Dr. Dhruv, I've often seen that people have difficulty picking the right masks and then not using them correctly. I mean, the vast majority of people, I would argue, don't use them correctly, which defeats the purpose of wearing them in the first place.
Yeah, with regard to masks, here's another, I have seen so many advertisements of these valved masks that come in and, it says some form of 95. N95 masks are the masks that we wear, the healthcare providers wear in hospitals. But these are not the masks that you need at home to wear. Basically, you need to wear a mask that covers your nose and covers your mouth, and it could be a cloth mask, it could be some of the surgical masks that you can buy at any pharmacy. All of those are adequate. Even a cloth mask is adequate and will decrease the possibility of transmission of COVID if you have it. I would be wary and stay away from these fancy looking masks which have a valve on them. Those have absolutely no meaning and should not be used. And I still see a few people wearing them, and I still see them being sold, which is unfortunate because they really should not be used.
Doctor, one more question, doctor. The ThyroCare lab has tested for antibodies, and they have given one statistics, that is in India about 18 crore people have undergone already the COVID, and to what extent it is correct antibody test, and whether the antibody test gives correct test or not.
So I think this 18 crore number is
on statistical basis, I think.
Yeah. There's some speculation and there is some conjecture with regard to that. Just briefly, I'll touch upon the antibody testing. Antibody testing, as of right now, it has no relevance in helping you or me if we are having symptoms and we want to find out if we have COVID or not. Right. So I simply put, it is not a test right now that any of us should be using for the sake of identifying whether, if we were to start having symptoms today or yesterday or have exposure to somebody that has turned COVID positive, the antibody test has no relevance. Right. The way that antibody tests work are that several days after you have exposure to a virus like COVID, the body starts generating antibodies. And even in these antibodies, there are different types of antibodies, some that come earlier, some that come later. So for the purposes of diagnosing COVID, it has no relevance. Antibody testing has more relevance to a little bit about what you were speaking is at a population level, to establish what is the extent of exposure that a population may have had to a disease like COVID. Towards that, there are some antibodies that are coming in that are fairly well validated, that are very specific to antibodies. The other problem with antibody testing is that what happens is that sometimes these antibody tests test for antibodies that may even be produced in some other viral diseases. So they're not very specific to COVID always. But however, there are now COVID specific antibody tests that are around and are being used. But the utility of these, again, is more at a population level to establish what is the level of exposure in a population, and something that is very often done retrospectively. And the way that they work is, I think Dr. Farzan had alluded to this earlier, is that there is no doubt that the extent of infections, we have 1.5 million proven positive cases in India today of COVID-19. There is no doubt that the true number of positive cases is going to be higher than that. Now it is a matter of conjecture whether it is twice as much, thrice as much, or 10 times as much. And epidemiologists at some point in time will make that determination using antibody tests which are conducted at population level at large. That's when we will be able to answer that, actually what was the actual extent of infection in the population at large. Was it, twice as much as the number that we have, or 10 times as much as the number that we have? So I think this 18 crore number is one of those speculative models that have probably been devised by some epidemiologists. At this point of time, I really wouldn't pay too much attention to it. It's hard to know whether that's actually true or not. And we should just stick with what we know. What we know is that let's be safe, let's socially distance, and let's take care of ourselves. So these things will play itself later. They will be much more helpful in a retrospective analysis down the line when we want to look at things. Right now, I don't know if it helps us one way or the other.
Thank you, doctor. One more thing. Whether the asymptomatic patient will spread COVID or not?
Yes, this is a question that has been answered now. Asymptomatic patients can spread COVID. I think there is enough evidence earlier on in the course of, in when we were in March, April, there was some speculation, some conjecture, and some doubt on whether asymptomatic patients can spread COVID. But that has been proven to be untrue. Asymptomatic COVID patients can spread COVID.
Thank you, doctor.
Hello, can I ask question?
Sure.
Yes, yes, Rotary Shahas.
Yeah. Doctors, I have one question. Those who have recovered from COVID, are they again susceptible for another attack of COVID? That is number one. Or those who are coming in contact after they have recovered, are they susceptible?
Again, a great question, and one that is being actively researched as we speak. It seems to be clear that patients who have had COVID and have recovered from COVID, they do develop a certain amount of immunity to
Request
COVID.
was to mute all.
That is has been proven to be true. Now, the extent to which that immunity would last, in terms of how long it will last, will it be lifelong? Will it last for a few weeks? Will it last for a few months? Is still not known. Right. So while it is safe to assume that we will have some level of immunity if we have had the disease and have recovered from it, the extent of that immunity is still not known. And again, something that we will find out in probably a few months, maybe even in a few years.
It could create a false sense of security, perhaps, doctor.
Yes, that is definitely possible. So again, like I said, I don't think that in terms of the precautions that we are taking, we should have any laxity in the precautions that we take purely on the basis that we have recovered from COVID, because it is not known, how much that immunity is and how long it will last. So it would be better to be cautious in such a scenario and continue to be cautious.
So in case of others also, the same rule applies, right? Those who are coming in contact with the patients who have recovered from COVID.
So you mean to be so your question is with regard to the is it possible for patients to infect other patients after they have recovered from COVID? Is that your question?
Yeah. Yes.
Yeah. Yeah, no, I think from that standpoint, it is pretty clear that the rates of infection or the infectivity of patients with COVID drops off. So after you have completed your quarantine period or your recovery period, which is currently at 17 days, the chances that those patients would continue to infect others is very, very, very low.
Dr. Dhruv, I had a question. One of the big labs, one of the big organizations, sorry, I think the CDC, have now recommended 10 days or something like that. They have reduced by a significant percentage. Does that sort of make sense in our experience?
Yes, yes. I think we will find as we come upon more data, especially related to infectivity patterns, we will probably find that I think 17 days may be on the longer end. Just again, this is just speaking historically from similar viruses, similar coronaviruses that we've had in the past. Usually, their infectivity periods are lower, and so we may find after a while that the duration for quarantine and may become lower, and the need for the infectivity period may become lower. And we've already seen that, like you rightly mentioned, some of the other organizations have already started reducing that time period.
It raises an interesting question. I don't know the answer to it. That let's say someone is positive on RT-PCR, and then after 10 days you do an antigen test, and the person is negative. Would that be definitive enough, or it would still be suspect?
So, firstly, antigen tests are not very good for negative tests, right? Because their specificity is pretty low. I'm sorry, their sensitivity is pretty low. So the chances of false negatives with antigen tests are quite high. So to answer your question, if somebody did an RT-PCR and was positive, uh, I don't see any need currently to do an antigen test after that. If anything, you would repeat a RT-PCR, because even if for some reason you still suspected that a person may have active infection and you wanted to evaluate that, you would repeat an RT-PCR. Because if you did an antigen test and it came back negative, it really wouldn't tell you a whole lot, because you would still question whether it was a false negative, and then you would have to do an RT-PCR. So I don't really see the
So
scenario
both
for
sides of
that.
the curve, you could have a false negative.
Yes.
Makes sense, yeah.
Yeah. So I actually would not recommend that sequence be followed at all, actually.
Thank you.
Can't hear you, Sunil.
Yeah. Last question, please. Anyone else? Thank you. May I request now Rotarian BL Srinivas, President Nandani, to deliver vote of thanks.
Thank you. Good evening to everybody. I am Srinivas. Before going to the vote of thanks, my question is there. I thought of asking a question before giving a vote of thanks. One is, Doctor and Farzan, is it your treatment will be covered by insurance, regular insurance?
I think you'll have to check with your individual insurance policy. What I do know,
yeah,
the IRDA has clarified that a COVID-related illness should be treated like any other illness. So if other illnesses are covered, it should get covered. In terms of covering people who then don't go to the hospital at all and they are covered, they are maintained only at home.
Okay.
I am less sure that they would cover that. What has happened, however, is insurance in COVID have come into much sharper focus. People are saying, can I buy a COVID policy? If I do buy a COVID policy, what is the waiting period? I presume it's typically 15 days or thereabouts. Does my existing policy cover COVID? And I think there the clarification is it covers it like any other illness.
Yeah.
But if someone is asymptomatic and getting cared for at home, would the insurance policy cover it? I'm not sure it will actually, but there is a lot of discussion and debate on this topic, and it will bring this whole matter of insuring people out of the hospital into sharper focus, which is a good thing.
Okay. Do you say that individually we have to inquire with the insurance policy people? I feel it is easy that, since you are giving the service provider, nightingales, if you keep ready, that will be much useful to the future patients.
We are talking to the insurance company, sir.
Yeah, insurance company. Yeah.
It's a very valid point. Yes.
Yeah, that will be nice before taking up any assignment. Okay. Anyway, it's a wonderful session. We had about 1.5 hours, especially for the COVID-19. It's our future. ನಮ್ಮ ಭವಿಷ್ಯ. COVID-19 ಜೊತೆಗೆ ನಮ್ಮ ಭವಿಷ್ಯ ಹೇಗೆ ನಾವು ರೂಪಿಸಬೇಕು ಅನ್ನೋಂಥ ವಿಚಾರದೊಳಗೆ ಕ್ಲೌಡ್ನಲ್ಲಿ ಮಾಡಿರುವಂಥ ಡಾಕ್ಟರ್ ಧ್ರುವ ಜೋಶಿ ಅವರು ಮತ್ತು ಫೆರ್ಜಾನ್ ಇಂಜಿನಿಯರ್ ಅವರು ತುಂಬಾ ಸವಿಸ್ತಾರವಾಗಿ ನಮ್ಮೆಲ್ಲರ ಒಂದು ಪ್ರಶ್ನೆಗಳಿಗೆ ಉತ್ತರವನ್ನು ಕೊಟ್ಟಿದ್ದಾರೆ. ಈಗ COVID-19 ಬಂದ್ರೆ ಯಾವ್ಯಾವ ತರ ನಾವು ಯಾವ ತರ ನಾವು ಪ್ರಿಕಾಷನ್ ತಗೋಬಹುದು ಮತ್ತು ಕ್ಲೌಡ್ ಸರ್ವಿಸ್ ಅಲ್ಲಿ ಹೋಮ್ ಕೇರ್ ನೊಳಗೆ ಯಾವ ತರ ನಾವು ಸರ್ವಿಸ್ ತಗೋಬಹುದು ನೈಟ್ ಆಂಗಲ್ ಮೂಲಕ ಅಂತ ತುಂಬಾ ಸವಿಸ್ತಾರವಾಗಿ ಹೇಳಿದಾರೆ. ಹಿಂದೆ ಏಡ್ಸ್ ಬಂದಾಗ ಕೂಡ ತುಂಬಾ ಪ್ರಿಕಾಷನ್ಸ್ ತಗೊಳ್ತಾ ಇದ್ರು. ಆ ಪ್ರಿಕಾಷನ್ಸ್ ಏಡ್ಸ್ ಅಂದ್ರೆ ಏನಪ್ಪಾ, ಬಂದ ತಕ್ಷಣ ಜೀವ ಹೊರಟೋಗುತ್ತೆ, ಇನ್ನಾಗೋಯ್ತು, ಇನ್ನು ಮುಗೀತು. ನಮ್ಗೆ ಈ ಮೀಡಿಯಾದವರು ಈ COVID-19 ಬಂದ್ಬಿಟ್ರೆ ಆಗೋಯ್ತು, ಅವ್ರ ಜೀವ ಕಳ್ಕೊಂಡ್ಬಿಡ್ತಾರೆ.
We can't hear you.
I think there is some internet issue, I believe.
Yes.
ಯಾರಪ್ಪ ಕೇಳಿಸ್ತಾ ಇಲ್ವಾ?
ಈಗ ಕೇಳಿಸ್ತಾ ಇದೆ
ಸರ್. ನಿಮ್ ವಿಡಿಯೋ ಆಫ್ ಮಾಡಿ, ಇಲ್ಲ ಅಂದ್ರೆ
ಆಫ್ ಮಾಡ್ಲಾ?
ಆಮೇಲೆ ಆಫ್ ಮಾಡ್ಬಿಟ್ಟು ಮಾತಾಡಿ.
ನೋಡಿ ಕೇಳುತ್ತೆ ಇವಾಗ?
ಅವರು ಬ್ರಿಗೇಡ್ ಅಲ್ಲೇ ಇದ್ದಾರೆ, ಬೇಕಾದ್ರೆ ಅಲ್ಲೇ ಸ್ಟುಡಿಯೋಗೆ ಬಂದು ಮಾತಾಡ್ಬಿಡಿ.
ಅದೇ ಬಂದ್ಬಿಡ್ತೀವಿ. ಸೊ ಅದರಿಂದ ದಿಸ್ ಅ ರೈಟ್ ಟೈಮ್. ಒಂದು ಒಳ್ಳೆ ಸೆಷನ್ ಆಯ್ತು. ತುಂಬಾ ಓರಿಯನ್ ಗೇಟ್ವೇ ಪ್ರೆಸಿಡೆಂಟ್ಗೆ ನಾವು ರಿಯಲಿ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ಬೇಕಾಗಿದೆ. ಇಂಥ ಒಂದು ಒಳ್ಳೆ ಡಾಕ್ಟರ್ಸ್ ನಾವು ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡಿ, ಅದು ರೈಟ್ ಸಿಚುಯೇಷನ್, COVID-19 ಇರುವಂತ ಇಂದು ಒಂದು ಸಿಚುಯೇಷನ್ ಅಲ್ಲಿ ನೀವು ಇಂಥ ಉತ್ತಮವಾದಂತ ಡಾಕ್ಟರ್ ಮತ್ತು ಸರ್ವಿಸ್ ಪ್ರೊವೈಡ್ ಮಾಡುವಂತ ಫೆರ್ಜಾನ್ ಅವ್ರನ್ನ ಕರೆದಿ ಈ ಒಂದು ಸಭೆಯನ್ನು ಮತ್ತೆ ಈ ತರದೊಂದು ಟಾಕ್ ಏರ್ಪಡಿಸಿದಂತ ಧ್ರುವ ಜೋಶಿ ಅವರಿಗೆ ಓರಿಯನ್ ಗೇಟ್ವೇ ಮತ್ತು ರೋಟರಿ ನಂದಿನಿ ಮೂಲಕ ಅವರಿಗೆ ಐ ವಿಲ್ ಗಿವ್ ಎ ಸ್ಪೆಷಲ್ ಥ್ಯಾಂಕ್ಸ್ ಟು them, sir. And once again, I'll give a vote of thanks to Mr. Farzan, an engineer also, since he gave a lot of input on Nightingale services and also how to take the right decision on 4 T's. I can say track, tracing, testing, and treatment. So all these things is very, very important. The 4 T's we have to take care. If we take a 4 T, these things adopt means definitely we will win over the COVID-19. For having arranged such a good session, I give a special thanks to President Orion Gateway, that is Rotarian Anupallavi, and Club Secretary Mr. R.T.N. Sunil Sachdev, and Club Service Director Sanjay Shamnu. At the same time, from our club, the Secretary Mr. C.R. Kumarswamy, and Club Service Director Mr. Manjunath. With the effort of Mr. Manjunath only, we are able to do this joint speakers meet. And year afterwards, we would like to do more and more speakers meet, and more speakers will be called, and it is going to be jointly organized, and it is going to be more useful to all our members. Thank you very much, Mr. Manjunath. And I would like to recognize some of the people I know from the Orion Gateway also. I would like to recognize Balraman Menon and Mrs. Balraman Menon, and our world-class trainer, Mr. Ashwath Ramaya is there. I thank you, Mr. Ashwath Ramaya ji. And our Sergeant Arms Chairman Suresh Mungarwadi, and our IPP Madhusudan Bide, and Shivmurthy, our Joint Director, and some of the our Rotarian members, and Orion Gateway Rotarian members. Thank you very much for coming and participating in such a wonderful session. Thank you all.
So that was really good and kind words. I would like to just add on that our great speakers today was referred by our public image director, Rotarian Aarti Madappa. So would like to thank her for introducing the doctors to us. And I would love to say that our club service director is Rotarian Geeta Menon, and she's put in lot of effort to bring amazing speakers to our program and to our club. And thanks to both the ladies here. And thanks to our secretary and our club secretary, Rotarian Sahadev. And thanks to all the Rotary Nandini members and Rotary Orion Gateway members who have come here and who have listened to the doctors so patiently. And the doctors have been so kind enough to answer all our queries. And today we are going to sleep well, knowing a lot of things about COVID. Thank you so much, doctors. Thank you so much, friends.
Thanks a lot, doctors. It's a really wonderful session and all our queries were answered. A lot of doubts were cleared because we are living in a most uncertain time as of now. We don't know what to do, what not to do. And it's really a great session, good learning for us. All our doubts are cleared. Before we end, may I request the Secretary, Kumaraswamy of Rotary Nandini, to make the announcement if there are any.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Good evening. Our immediate past president, Rotarian Madhusudan BD, celebrated his birthday on 17th July 2020. Our member, Rotarian Nirmala Guttal, celebrated her birthday on 22nd July 2020. Our new member, Rotarian Parimal, celebrated his birthday on 10th July 2020. These are the announcements. Thank you.
Thanks a lot. Thanks a lot.
I'd just like to say a big thank you to my colleagues also who are here and who have come for this. Before I once again say thank you, Fajan and Dhruv, for being with us today.
Thank you. Thank you. Before we close the meeting, there's an announcement from our club also. On 3rd of August, Rotarian Dr. Reena will be celebrating her birthday in this week. So that's the announcement from our club.
Thank you.
Thank you. Thank you. So may I request President Anupallavi to now adjourn the meeting.
Thank you, Sukhdev.
Thank you.
Meeting
Thank you.
adjourned. Thank you. Thank you.
Thank you, Anu.
Thanks all.
Thanks
Anupallavi, we are
Thank
meeting
you.
at
Bye.
Galaxy Club.
Anupallavi ji,
Yeah.
namaskara.
Sir, namaskara. Thank you, sir. Tumba thanks.
ನಿಮ್ಮ ಹತ್ರ ಇರೋ ಮೆಡಿಸಿನ್ ಅಲ್ಲೇ ಒಂದ್ 2 ವ್ಯಾಕ್ಸಿನ್ ಕೊಡಕ್ಕಿಲ್ವಾ ಎಲ್ಲರಿಗೂ?
Sure, sir. Doctors ಇಲ್ಲೇ ಇದಾರೆ, ಅವ್ರ ಪರ್ಮಿಷನ್ ತಗೊಂಡು ನಿಮ್ಗೆ ಕೊಡ್ತೀನಿ.
Thank you.
ಡಿನ್ನರ್ ಗ್ಯಾಲಕ್ಸಿ ಕ್ಲಬ್ ಅಲ್ಲಿ ಅನು
Yeah, who is that?
ಡಿನ್ನರ್ ಎಟ್ ಗ್ಯಾಲಕ್ಸಿ ಕ್ಲಬ್ ಆಶಾ ಕುಲಕರ್ಣಿ ಹೌಸ್.
ಸರ್ ನೀವ್ ಎಲ್ ಬೇಕು ಅಂತೀರಾ ಅಲ್ಲೇ ಎಲ್ಲ ರೆಡಿ ಆಗಿದ್ದೀವಿ. You're all welcome to come.
But you should make sure some corona symptom person should not sit next to us, madam.
We'll make sure, sir. Thank you. Thank you so much.
Good night.
No.
Bye bye.
Thank you, Srinivas, sir.
Bye.
Thank you.
Bye.
Bye. Bye.